Hi everyone, I'm Dr. John Kennedy. Welcome to MD-VOD, Your Health Live and On Demand. Each week, we examine a medical challenge to help you better understand what the challenge is, who's at risk, the common symptoms, how to make a diagnosis, treatments and therapies, and whether insurance covers the costs. Today, we're talking about the human immunodeficiency virus, or HIV, the virus that causes AIDS. We've learned a lot about HIV since the first diagnosis in 1980, and with research, increased public awareness, and education, the therapies and diagnostic tests for HIV have continued to improve. Though, despite these efforts, still more than 1 million people are living with HIV in the United States, and more than 500,000 have died after developing AIDS. Worldwide, the number of people living with HIV rose from 8 million in 1990 to 34 million by 2010. Fortunately, the number of new HIV infections and deaths from AIDS has steadily declined, mostly from people receiving special medication known as antiretroviral therapy. Later in the show, we'll be joined by HIV expert Dr. David Hardy to help us better understand HIV and AIDS. But first, we'll discuss how HIV affects our body in our anatomy lesson. Welcome to our anatomy lesson on HIV and AIDS. HIV is a virus that attacks our immune system, making the body prone to infections. It starts like a flu-like illness and can cause vague symptoms like body aches, fatigue, and a sore throat, which is usually followed by a period without symptoms. Though as the virus replicates and multiplies, the disease progresses and AIDS develops, leading to cancers and a variety of bacterial and parasitic infections which affect our brain, our lungs, and our GI tract. Make sure you stick around because up next, we'll have HIV expert Dr. David Hardy to answer your questions live. Hi everyone, we're back on MD-VOD and we're talking today about HIV and AIDS. And we're joined by HIV expert Dr. David Hardy. Dr. Hardy, thanks for joining us.
Thank you, John.
Hey, so what is HIV and what's the difference between HIV and AIDS?
HIV is the name of the virus, the human immune deficiency virus that causes AIDS. HIV was a new virus that was discovered in 1983. There were viruses similar to it previously, but this was a brand new virus that had never been seen in humans before. And HIV causes a disease called the acquired immune deficiency syndrome, or AIDS. So simply speaking, HIV is the cause of AIDS.
Mm-hmm. And what population is at risk or most at risk for HIV?
That's a great question, John. I think the best way to answer that is to say that everyone who has sex, who uses drugs, not necessarily intravenous drugs, but uses drugs in general, or alcohol, mind-altering substances that can change one's judgment in terms of sexual behavior especially, can get HIV. Previously, we used to look at only certain risk groups for HIV infection, but we have learned over the past 30 years that this epidemic has been known about, that anyone can get HIV. There's nothing specific about gay men, about injection drug users that makes them get HIV any more than anyone else. It's simply the behaviors that one does that can lead to infection with HIV. So basically what I tell people is that anyone can get HIV infection, depending upon what they do.
Wow, that's a great point, and something that is a really important take-home is that everyone is at risk for this virus. And it seems like we spent a lot of time over the past at least couple of decades talking about who's at risk, and it seemed like we kind of got caught up in risk factors that might not be as important. Your point about alcohol, most of us drink alcohol, and it's more to do with if you drink alcohol, you might have behaviors that put you at risk. I think that's a great point.
I think the important thing about HIV is the fact that we use, very early in the epidemic, we use some of the characteristics that people normally sort of had in their lives, what we call their demographics, their sexual orientation, some of their sexual practices, some of their drug use practices, and use that to classify who got the disease. Those were only risk factors, but not the whole story. So as the time went on, we discovered that heterosexuals get HIV even more commonly globally than gay men. In Africa, the epidemic is almost entirely heterosexual. So there's nothing about gay sex between two men that makes HIV more likely. It's simply the fact that one person who is infected transmits the virus to another. And that's really as simple as it goes. And we basically break that down to know how someone gets HIV based upon whether or not they have contact with certain body fluids. Blood and sexual secretions, semen in men and vaginal cervical secretions in women are the ways that the virus is transmitted. We also know, importantly, how the virus is not transmitted by saliva, by tears, by sweat, by simple non-sexual contact. So we really have a very good idea exactly how this virus is transmitted from one person to another.
That's another great point. I remember in my training in the 90s learning about how HIV is not transmitted by physical hand-to-hand contact or saliva. And on that note, blood, it's a blood-related virus. Are transfusions still a problem? Does that put you at risk with blood transfusions today?
Good question. Very early on in the epidemic, what we found was that there were contaminated units of blood. And particularly, I know at my hospital at Cedars-Sinai, there was a big problem of transmission by HIV before we were able to screen blood. The first HIV test that was developed was meant to screen blood products, not people, but to make the blood supply safe. Since that time, not only does that screening test, but other more specific screening tests are utilized to be able to make sure that all donated units of blood do not contain the virus or the antibodies against the virus from a person who may unknowingly donate blood without really understanding they have the infection themselves. So the number that is used today is that the chances of getting an HIV-infected unit of blood is less than 1 in a million. Wow. Which is much, much smaller than a lot of risk we take every single day when we get on the car and drive around.
So less than 1 in a million from a blood transfusion of transmitting the HIV virus. What about, you're an HIV expert. What is a common set of symptoms? How might someone come to you, Dr. Hardy, with the HIV virus? What are some of the symptoms that you might tell someone to be aware of?
Sure. Probably the most common way that people are first diagnosed with HIV is simply by doing a blood test. And in fact, our Centers for Disease Control recommends that every U.S. citizen between the ages of 13 to 64 have HIV blood test at least once, and more often if they have risk behaviors that may put them at risk. So it should be repeated in many people. The most common way people present to me is basically without symptoms at all. They come because there's a very long incubation period in between the time the person is first infected and the time that they finally become a symptom of anywhere between about 8 to 11 years. Wow. So there's a very long period of time that the virus basically sort of cooks inside the person, slowly chipping away the immune system before the symptoms really cause any kind of significant problems. As mentioned previously, there is what we call antiretroviral syndrome, a flu-like illness that can occur in about 70–75% of people when they first are infected with the virus. That lasts about maybe a week, maybe 10 days, and it goes away. And then most people go for a very long period of time before they have any signs or symptoms again. When someone does start to have symptoms, it's usually most commonly things like fatigue, swollen lymph glands, especially in the neck, under the arms, and the groin, sometimes skin problems, like fungal infections of the fingernails, on the skin, vaginal infections caused by Candida, mouth infections caused by Candida, called thrush, and then slowly kind of weight loss, wasting of body weight, and kind of getting more and more tired all the time. The skin is a very important place where many of the first kind of signs also oftentimes show up as well. But those are usually not until someone has much more severe disease after being infected. For some are usually 6 to 8 to maybe 10, 12 years.
Wow, so long incubation period. But they're diagnosed, if they were diagnosed 6 to 8, 10 years right when the virus infected them, they would be HIV positive. Is that correct?
Exactly.
Okay.
The test that we use to diagnose people most commonly is an HIV antibody test. An antibody is a protein that our body makes as a part of an immune response or a resistance against a invading virus, bacteria, whatever, in order to show that in this case, that the virus is there. The HIV antibodies can be detected in saliva, by swabbing someone's gum, by a finger stick, by drawing blood, and these are ways that the diagnosis of HIV is made most commonly. That means the person doesn't necessarily have AIDS, but they do have HIV infection. We don't really know about a diagnosis of AIDS until we do more specific sort of tests of the person's immune system, or carefully go through their history to make sure they have or have not had what we call an AIDS-defining illness, like a severe opportunistic infection or cancer that may actually diagnose AIDS.
And on that note, let's say someone was infected with HIV, didn't know it, they went 6 to 8, 10 years without knowing it, and then they develop AIDS. Their immune system is compromised and they start manifesting different signs and symptoms. What are some of the things that you might see on exam, let's say on the skin, or how might people present to you?
Sure. Well, probably the most characteristic thing we see in someone who's diagnosed with AIDS or an AIDS-like sort of syndrome is going to be weight loss. Probably the fact that you can see people's temples sort of starting to thin out, their face may look a little thin, they're usually getting thinner all the time because the virus is slowly using up a lot of their body's energy that causes weight loss. We see what's called seborrheic dermatitis, sort of white, flaky, some kind of oily areas across the eyebrows, and the man's mustache, between the nose and in the corner of the mouth. We see candle infections, yeast infections in women, vaginally, in the mouth, in both men and women. Kaposi sarcoma is a ever decreasing, but a formerly most common sort of AIDS tumor on the skin. They're kind of a purplish, violaceous sort of color. But I think the most important thing that we see are little things, little kind of dry skin, flaky skin, gnarly looking toenails, evidencing fungal infection in the toenails that are kind of hard to get rid of. Things that you may not kind of think as being particularly immune deficiency, but that's why we've developed a huge specialty part of medicine that can look at these things and say your immune system should be taking care of those things. If you have enough of them, one after the other, that's a great reason to look for this kind of disease. One by itself probably isn't enough, but a succession of these things is what really tip us off of really needing to look at someone's immune system much more carefully and, of course, do an HIV test.
It's a great summary of what the symptoms are and what we should watch out for. Once someone's diagnosed with HIV, what are some of the therapies available that seem like have made a huge impact on at least the death rate in HIV and AIDS?
Sure. I think that's kind of one of the that's one of the best parts of the whole story, really, John, is the fact that from the time this virus and this disease were discovered in 1981 for AIDS, 83 for the virus, by 1996, a relatively short time in the history of most medical conditions, we had effective therapy. That effective therapy, starting in 1996, has become better, has become safer, has become simpler, and although we cannot cure HIV or AIDS at this point, we can certainly suppress the virus that causes it to a level that we can, in kind of best sort of way of thinking about it, put the virus in remission so that the virus is no longer doing damage to the immune system. There are over 28 medications now which have been licensed by our federal FDA that are used in combination. The real important key for why HIV medications work is because they're used in at least 3 drugs at the same time. When we use one, when we use 2, they didn't work. When we put 3 together, they actually work very well. We've actually now just seen the recent licensure of our 3rd medication, which has 3 or 4 medications all combined into one pill, which makes taking 3 or 4 medications, which can sometimes be very difficult, very easy in those cases, where the person just takes 1 pill a day and actually has the benefit of a full, what we call a HART, or a highly active antiretroviral treatment regimen, all in 1 pill. HART, we call it, H-A-A-R-T. So it's something that, that has actually been a real success story. There's been few other kind of illnesses that we've taken from being totally almost a death sentence to something that is now what we call chronic treatable illness in people by simply taking as little as 1 pill a day.
Wow. And my next question is, how does insurance cover some of the costs? For example, a consultation with you and some of these treatments that you talked about, the 1 pill that contains all these medicines that sound like they're synergistic.
Sure. You know, the good news is that since the licensure of the first medication for HIV back in 1987, insurances, both private as well as federal and state, have covered HIV treatments pretty uniformly from the beginning until the present. So all HIV-related medical care, doctor's visits, blood tests, laboratory examinations, all the medications which are approved by the FDA, and we have several of them now, are all covered by insurance. Here in California, particularly, we have particularly good coverage for persons who don't have or can't afford private insurance with a program called ADAP, the AIDS Drug Assistance Program, a both federal and state funded program that actually makes HIV medications available to those who make less than $50,000 a year, even could have insurance but don't have pharmaceutical drug coverage with their insurance. So, you know, the good news is that our federal and state government has done a really good job of making sure that these life-saving medications do get to those who need them, so that we can cut down on not only progression of the disease to AIDS and death that used to happen before 1996 very commonly, but also we can stop transmission from one person to the other. One of the biggest benefits we noticed just recently of treating HIV-positive people is not only a benefit to themselves, but also by lowering the amount of virus in their blood and therefore in their sexual secretions, we also can really decrease transmission from one person to the next, which is becoming a very important way of combating the epidemic as a whole.
Does that work both for partners, I would see, spouses of people that are HIV infected, by taking medications that lowers their risk? Is that right? If they're active, sexually active?
Quite a bit. You know, we still, I think it'll be a long time before we ever tell people one HIV positive, one HIV negative, or I would say one HIV unknown, one HIV unknown or known. It's hard to sometimes know for sure because people don't always exchange that information when they're having sex. Condoms should always be used. I think that's the most important thing I want to emphasize, is that even with good anti-HIV therapy and lowering the risk substantially, over 95% is the risk lowered, we still cannot completely decrease the chance of HIV transmission by medications alone. Because HIV right now is an infection forever and can cause problems and require medication for a lifetime, preventing its transmission is still very important. So yes, answer to your question, if we have a positive person and a negative person having sex, we will tell the positive person, if they're not already on medication, one of the things they should think about is trying to protect not only their sex partner or spouse, partner, whoever, by going on medication themselves, but also to benefit themselves. So it's really a two-for-one sort of situation of treating themselves, but also decreasing transmission to others. That's
a great point, and I just want to say it again. You know, everyone's at risk, and it sounds like, talking to Dr. Hardy, it's behaviors that put us at risk. If you're doing drugs and alcohol, you're more likely to engage in high-risk activities. And you know, you said it also, if you're engaging in high-risk sexual activity, you're also at risk. So it's a behavior-related thing. It's changed a lot, our thinking, over the last 10, 20 years. That was an outstanding review of the diagnosis, those at risk, the treatment. And make sure you stay tuned, because up next, we'll join Dr. Hardy live after our Apple a Day and how to prevent AIDS, HIV and AIDS. But thank you so much for joining us. That was an outstanding review.
Thanks, John.
Today, we have more tools to effectively prevent HIV than ever before. HIV testing is the first critical step to ending the HIV epidemic in the United States. And the CDC recommends that all Americans aged 13 to 64 get tested, and those at high risk get tested once annually. Some other important tools that decrease the risk of HIV include access to condoms, prevention programs, substance abuse programs with access to sterile syringes, and sexually transmitted infection screening. And for more information about HIV and AIDS, go to cdc.gov, because the more you know, the more successful you'll be at preventing and living with HIV and AIDS. I hope our show on HIV helped you understand the disease, how to prevent it, and what to do if you have it. And don't forget to like us on Facebook, follow us on Twitter, and share us with your friends and family. Also, subscribe to us on YouTube and sign up for the newsletter for updates on the show and the channel. And be sure to leave us your comments and questions so that we can always better help you. Also, send us your questions and tell us what you need to know. I'm Dr. John Kennedy, and you're watching MD-VOD, your health live and on demand here on emPOWERme.tv. We'll see you next time.